Well, hello and welcome to HealthLine on this Tuesday evening. I'm Jennifer Blomquist. Thanks so much for tuning in. I know you're going to love the show. You will walk away learning something. I can guarantee that. So if you're new to the program, I want to explain how it works. We are live in the studio and we keep our phone number up at the bottom of the screen, actually 2 phone numbers for you because we encourage you to participate during the show. We have a guest with us tonight. We're doing a women's health program, which is great. We haven't had the opportunity to do too many of those in recent years, so I'm excited to be able to do that tonight. We have a urogynecologist here this evening, and he'll be more than happy to answer your questions. So here's how you can do it. You can either call us on that phone number, 969-2720. You'll talk to a call screener first. You can ask the question live, which is great because the doctor may need to get more information from you. Maybe he can give you a better answer. You can have a nice conversation, and I really like that option. But I understand if you prefer to just give your question to the call screener, they will relay that to me, and then we'll get your question answered that way. Another new option, we just started it this past winter, is to text. A lot of people really like doing that. That's a little different phone number. It's 969-2730, and I want to assure you your phone number will remain private. We absolutely will not put that on the screen. If you feel comfortable, give us your name, maybe where you're calling from, and your question, and again, that's a great way to get your answer. So let's go ahead tonight and introduce you to our guest. Again, I said he's a urogynecologist, Dr. Scott Boyd.
Hi.
Thank you so much for coming on. I appreciate it.
Here. Thank you.
I'm sure most people watching will say, oh, gynecology, I know what that is. Urogynecology, maybe not so much. So why don't we just, before we get into some of the topics we were going to discuss, just talk about what that specialty is and why somebody might need a urogynecologist.
Sure. So it's a specialty outside of GYN. So you go through OBGYN residency programs, and then you get specialty training in female pelvic reconstructive and medical problems. So it's focused on female pelvic problems such as incontinence, prolapse, not just the surgical aspect, but even the medical aspects.
Okay. So would you say in general it's going to be an older population that would need this specialty, or do you feel like not so much?
It's more common in the 60 plus, but there are plenty of women who will have issues even in the childbearing ages. So we don't tend to see it in the 20-year-olds, but anybody beyond that starts having problems. The patients in the younger areas tend to be a little bit more better at non-invasive techniques as far as getting good outcomes. They tend not to have much prolapse and surgical needs, but yeah, it starts in the probably 20s and 30s and beyond. Okay.
So can you kind of discuss what is the pelvic floor? Is it just, is it all muscle, or I don't know, people probably hear it but don't know exactly what that is.
Sure. A good analogy, I think, for patients and people to think of it as a trampoline. So in a trampoline scenario, you have the frame of the trampoline. Think of that frame as the bone of the pelvis. And then you have the springs of a trampoline, and think of that as connective tissue and ligaments. And then you have the mat of the trampoline, and think of that as the muscles. And all of that is there supporting the whole bottom part of the pelvis. And that includes things like your bladder, the uterus, the rectum. And so that's kind of the structure.
And there can be issues. So people have probably maybe heard of the prolapse. Is what exactly happens when there's prolapse? Is it all based on something with the muscle?
It can be, yeah. So any of those structures, I mean, we typically don't see it in the bone, but you know, in the ligaments, connective tissue, and the muscle, you can have defects in those areas. And then that can lead to things like, you know, the normal terms, a dropped bladder. Okay?
Yeah, I've heard
that. We call that cystoceles, but you'll have a falling down of those structures. So the vagina is in some ways herniating down or falling down. But it doesn't have to be just the bladder. It can be the uterus. You can get uterine prolapse. It can be on the bottom part of the vagina. We call that a rectocele. Where think of these as like herniations of the vaginal wall or the pelvic floor.
Do most women know right away if there's an issue, or could you have this issue and not know until maybe you have an exam?
Both. And so if you think about number-wise, any woman who has had a vaginal delivery, 50%, so 1 in 2 of those women will have some degree of pelvic floor prolapse. Most of the time it's asymptomatic. So early on they don't have symptoms. They may not know it's there, and that's okay. That doesn't have to be addressed. But later
even if
on,
they do have the prolapse, as long as they're not having
if it's
symptoms?
really mild,
Okay.
right. So if there's
Okay.
degrees of prolapse, and the early degrees are okay. That's not anything that necessarily needs to be addressed. If they bring it up with their physician or a urogynecologist, we can encourage them to do things that are simple, like Kegel exercises, physical therapies, non-invasive techniques. If it advances, then it tends to become symptomatic.
Is it painful for women, or is it just something that's maybe more of an annoyance?
It's something in between.
Okay.
So if it's something that's terribly painful, then we tend to think there may be something else going on. They need a different or more inclusive, specific workup. But it can be painful. It can create back pain, low back pain. A lot of times women describe it as pelvic pressure. Feels like something's falling down. I have pelvic pressure. It's a lot of times associated with bladder dysfunction, so either leakage of urine or retention of urine. So more often than not, it's just more of just a vague kind of pressure, discomfort, heaviness, or they look and they see something coming out of the vaginal space.
And I was wondering if it happens gradually, or can it be sudden, or can you have both scenarios?
Both. So
okay.
most of the time, I would say it's more of a gradual process, and that's a problem, right? Because then you start to learn to live with it,
Sure,
and then
get
you're
used
like,
to it.
I've been living this for the average amount of time that a female patient will live with this before they even mention it to the physician for the first time is about 7 years.
Wow.
So that's huge. Now, flip that coin over, it can be very sudden. I have a number of patients that'll come in weekly, and they'll pinpoint. I had a couple of patients today. They can pinpoint the day and the time.
Okay.
And so sometimes whatever structure is breaking, whether it's a ligament, usually it's a ligament dysfunction that becomes more acute, and like, hey, I was fine, and then all of a sudden, boom. So.
Now, do you have to do any imaging or scans to be able to diagnose it, or can you just do it through a pelvic exam?
Most of it you can diagnose with a good pelvic exam and a good history and just talking to the patient. There are some specialty tests that we'll do, especially as it pertains to bladder dysfunction. So if you start getting into the realm of leakage of urine, since there's so many different reasons why you can have leakage of urine, we'll do some very specific testing. But for the most part, it doesn't require a whole lot of imaging. We're not typically ordering CT scans, MRIs, and ultrasounds. Most of the time, it's just a good physical and history.
So, people don't like to have surgery. We were talking about this before the program. It's recovery time. I think surgery, I'm sure it's not scary for you because you're a surgeon, but for most patients, it's just something you would dread. So you kind of mentioned if they're a candidate, you would start with conservative treatments. Can you touch a little bit more on the Kegel exercises? Years and years ago, we did have a physical therapist who kind of specialized in that. And so I had never heard of it before, but she was telling people that, you can she talked about like regaining control of your pelvis.
Yeah. So Kegel exercise, the stats on that. So about half of women who we're trying to train on Kegel exercises will ask them, hey, do you do Kegels? Oh yeah, I do Kegels. I've been doing it since I delivered.
Oh, okay.
And then you start coaching them on it, and you'll find out that about half of them are doing it wrong. They're actually pushing and not pulling. So
okay.
It's the best way to think about it is think if you're trying to hold back a gas and you're like clenching your whole pelvic floor as tight as you can.
Yeah.
So you're trying to clench and pull upwards of your pelvic floor.
Okay.
And you don't want to hold your breath. You don't want to push. You're actually trying to do it without straining it. And a lot of times, again, 50% of people are actually pushing, which makes it worse and not better. So a lot of times we'll send patients to a formal pelvic floor physical therapist that can help coach them on those things.
Would there be any other conservative treatments that you can try beyond that? Or I don't even know if medications or injections.
It's probably not so much from a medication standpoint relative to prolapse. There's a lot of medication options when it comes to different types of leakage problems.
Okay.
When it comes to prolapse, we'll look at sort of risk profile. Is this patient chronically constipated and straining? What's her workout routine? Weight can be an issue. So we're trying to eliminate and alleviate strenuous chronic strain on the pelvic floor.
And I want to continue this conversation, but we did have somebody text in
Sure.
a message. So this is interesting. So this is from Wesley from Fort Wayne. Basically was asking if urogynecology can handle, if that specialty would handle the issue of kidney stones.
Short answer is no.
Okay.
So we kind of bridge the gap between gynecology and urology.
Yeah.
So think of gynecologists are people who are dealing with female pelvic problems such as bleeding, birth control, hysterectomies. And then you have urologists, and urologists typically will take care of men and
Sure.
women, and they'll be involved in things like kidney surgery to include kidney stones, bladder cancers, incontinence for both men and women, prostate issues. And so we bridge that gap, but we're still solely focused on female care. And one of the things that we do not do is kidney stones.
Okay, yeah, it was interesting. We did have a urologist on a few months back, and I was surprised when he said, I thought he was going to say he just treated men, but he said he does treat the women for the kidney stones. So, all right, well, thank you, Wesley, for that question. Just a reminder, you can call us and ask a question, 969-2720. You can text like Wesley did, that was great, 969-2730. And again, just want to remind you, your phone number does stay private if you want to do the texting route. So when you were talking about, conservative methods and then going into the surgery, I wanted to ask you about some exactly what happens during the surgery. Do you find that this tends to be a hereditary thing? If your mom or sister had it, are you at a higher percentage?
Yes,
for
short
that?
answer.
Okay.
One question I get pretty much every time a patient has significant prolapse is why?
Yeah.
Hey, how did this happen? What did I do? Why? And sometimes in medicine we don't know. Like we might not have the why. In this case, I always tell them it starts with genetics.
Yeah.
So ultimately it's a genetic predisposition. So for whatever reason, their genetics basically predisposed to have some weakness in that trampoline somewhere, and then a lifetime of risk factors, right? So, and the risk factors can be as simple as coughing, walking, running, laughing, sneezing, but then you start thinking about childbirth, multiple babies, big babies, long labors, birth trauma. What kind of a job are you living on a farm and you're lifting stuff all the time repetitively? You work in a factory. Anything that creates chronic pressure in the pelvic floor could even be chronic constipation, which we see a lot of. So, but it starts with genetics, and when I say that, most of the time the patient will say, "Oh yeah, my mom's had this. Oh, my grandmother had that. Oh, my sister's had this."
Yeah. When you were talking about women having a lot of children, what if you've had only C-sections? Does that change your risk factor?
Statistically, yes.
Because you have that scar tissue in there too. I didn't know, because I think they will do up to. I've had 4, but I know at least 3.
Yeah, I think they'll go
multiple.
up to 5 or 6.
Yeah.
The short answer is yes. It's not a guarantee. I've had patients who've never been pregnant and have prolapse, but most of the time, if you look at the profile, most patients have had multiple vaginal deliveries. By having C-sections and avoiding the birth trauma, it definitely reduces your chance, but it's not eliminate. And there are some countries, Brazil's a good example, where women will elect to have primary C-sections pretty much, almost universally.
Oh, okay.
And part of the thought process behind that is they're trying to save the pelvic floor.
That's interesting.
Even in America, a patient can elect to have a primary C-section or any C-section. She can just say, "Hey, I want a C-section," and that's okay to do.
See, and I remember reading about that issue years ago, that people were doing it not so much for the medical aspect of preventing pelvic issues, but just for convenience sake. I want to make sure, especially if you have other children. Like my situation was different. I didn't elect; I had to, but I didn't know that you were given the choice anymore. If that was still kind of controversial.
I'm not sure that they give them the choice, but if you bring the choice to the physician, they will honor that. So there's a lot of pressure, and it's less invasive. I mean, C-section's a significant surgery.
Yeah.
So I wouldn't advocate that everybody, follow the Brazil path where everybody's getting C-sections. But to answer your specific question, if you have a C-section, there is some thought and some data that says it reduces your chance. Again, not zero. I wouldn't advocate to to avoid vaginal births and just everybody get C-sections. I wouldn't advocate for that.
Well, it's just it's interesting to hear about how other countries, look at things too from the medical perspective. So what if you, are in a situation where you're going to have some reconstructive surgery? I realize there's probably not a cookie cutter formula. Everybody's probably different, but in general, can you talk about what you need to do in the surgery? And is it done laparoscopically?
Yeah, so it's definitely not cookie cutter. It's very much one of those things that's very personalized.
Sure.
Sometimes we are figuring out exactly what to do when we're actually operating. We generally have a very good idea of our approach, but it's a reconstructive process. So as you get in and you start to reconstruct and find out some more of the specifics of anatomy, sometimes you have to change your plan. It varies. There are purely vaginal techniques. There are open abdominal techniques.
Okay.
Most of the surgeries that we are doing is utilizing robotic or minimally invasive surgeries nowadays.
Yeah, I didn't even know if they would still do the traditional incision where it's
very
several
rare.
inches.
Yeah,
okay.
I've done this for going on 30 years now. I
Yeah.
can't tell you the last time I've done a big open
really?
incision. I don't remember when it was.
Yeah, I know the minimally invasive is
Mm-hmm.
definitely the way to go. Years ago, I remember the whole controversy about the mesh. I'm sure a lot of women would recall that there were issues, and you always see these commercials on TV from these legal firms like, if you had a mesh put in between such and such a time and experienced complications, you may be, able to sue. So there were complications. I don't remember the exact time frame, but I don't know if you want to talk about
Sure.
that. And is that something you still use, and should people be worried?
Sure. Long topic, but I can
Yeah.
hopefully give you a
Sorry.
60-second
You could
breakdown.
probably talk all night about that.
Yeah, I could. Think of it this way. So in 2019, the FDA took a specific mesh product off the market, or made them, forced them to do it.
Okay.
That mesh product was what we call a transvaginal mesh product, meaning that mesh was inserted in through vaginal incisions.
Okay.
And it was that specific product, and pretty much that only specific product, that created that whole storm of fear. And we've literally been diving, we've been digging out from underneath that now for many years now. So ultimately, the mesh products that we use currently, there are decades of use. So some of the mesh products we've been using for 50 plus years.
Wow. Okay.
Well studied, great data, and depending on the degree of prolapse, if you have to use a mesh product, such as something called a sacral colpopexy, which is we're using mesh to secure the whole vagina, that is still the gold standard. But that, again, that's a very specific, extreme form of prolapse. So most of our prolapse surgeries, we're not using mesh, but we do use it. It's still appropriate, safe, and effective. But it really kind of comes down to trying to eliminate some of this fear that still exists. It's gotten better since, but the mesh, that's been taken off the market, it was just one mesh product.
Okay.
And really, it wasn't so much the mesh itself, it was sort of the technique of how they're putting it in. And that's where I could get in a whole long hour conversation, but suffice it to say, we still use mesh, very appropriate to use in the right patient, and very safe and effective.
So is the mesh, I had read something that said it acts like a sling. Is that true so much?
Yeah, you could think of it that way. A sling is a very specific term that we use. There's a sling, which is a specific small, little tiny piece of mesh that we use to support the urethra for leakage.
Sure.
Then there's vaginal mesh that we use for significant prolapse. Most of the time, what we're doing for patients, and this may vary a little bit from urogynecologist to urogynecologist, but most of the time, depending on degree, we'll try to do what we call native tissue repair. So we're trying to avoid putting any foreign body in. And then if God forbid that fails, because about 10% of the time these things can fail, then we would opt more for a mesh type procedure. Or if it's a really bad prolapse, we're like, hey, your trampoline's gone. There's nothing I can use. And then we'll have to opt for mesh.
All right, interesting. Thank you for clarifying that. So I wanted to quickly take another question we received through text. It was from Nellie from Fort Wayne. She was asking what are urodynamics, and she wanted to know if tests are required before an appointment, or if you're required to go through some testing before you can have an appointment with a urogynecologist.
Sure. So urodynamics is a very specific test that urologists do too, but it's most in the realm of urogynecologists, and it's a test that's looking at the reason behind leakage.
Okay.
So if a female patient is having incontinence or leakage of urine, like I said earlier, there are multiple different reasons or problems that can lead to the leakage, and the urodynamic test is something that will help us delineate the specific cause, and then we can get really specific in the solution. And as far as the what was the other part of the question?
She wanted to know if you need testing
before
you can have your appointment.
Not before. So
Oh,
you typically, if a patient is having any of these issues, they can either go see their primary care, and then their primary care can do a quick initial evaluation, then refer. If they are like, hey, I know I'm leaking, or I know I have a prolapse, they can just skip that and come right to the urogynecologist. We'll start with a very thorough history, physical exam, and then from there we'll decide if any further testing is warranted. And urodynamics is definitely something that we utilize quite a bit.
All right, great. They just showed me the card. We have 5 minutes left.
Okay,
I told you
yeah,
it would go very
fast.
fast. It does go extremely quickly. But that's still plenty of time to get some questions answered. So again, you could text us 969-2730, call us 969-2720. In case I forgot to tell you this, if you're outside of Fort Wayne, it's still a free call. Just put 866 in front of there, and it won't cost you a cent. So we can get another question or two answered easily. Since we were talking, though, in the meantime about leakage, and I wanted to ask you about urinary incontinence, which before the show you were saying that a lot of people just kind of learn to live with it and they don't bring it up. It's kind of embarrassing, and I think I just hear a lot of women say, oh, if you laugh or sneeze or cough when you're older, you're just going to leak. That's just the way it is. Yeah. So can you talk about, there are two kinds, you said, of
multiple
leaks.
Two common ones.
Yeah.
So I would start with very common, but not normal. So at least 1 in 3 women will have some form of incontinence problems. It can start early, so you'll get a lot of women, again, around the childbirth, but you can have women who've never been pregnant, who are young athletes, great shape, they're running, they have a full bladder, they can leak. The younger the patient, we tend to be very successful in just teaching them Kegels, doing some physical therapies. Yeah. Later on in life, especially if it's been a chronic ongoing problem, if it's getting worse, then we'll do urodynamic testing to see kind of what it is. And as we delineate the different types, medicines can be very helpful. So there are different types of medicines for leakage. Okay. That's for what we call an overactive bladder, which is like, gotta go, I gotta go, gotta go.
Yes,
So that urge, and but bladder retraining, teaching patients how to double void, how to bladder retrain so they can re-expand the bladder. It's a very good techniques. Avoidance of things that can be bladder irritants, caffeine, chocolate, acidic foods, for what we call stress incontinence. Physical therapy, Kegels, and even slings, which is that minor surgical procedure for that. But we also have injections. Sometimes in overactive bladder, if the more conservative things fail, then you start thinking about Botox injections. I read that.
That was interesting. You always think of Botox as a cosmetic thing,
so we inject that into the bladder, or even something called sacral nerve modulators, which are like little pacemakers for the bladder.
All right, so you have a lot of different options.
Lots of tools.
And you were saying it's not normal, because a lot of people think that a little bit's okay, but I mean, if you have just a little bit, is it going to get worse as you get older if you ignore it, or could it just stay as a minor issue for
50-50.
Okay.
50-50. So, but still even good, and even if you have a little and you're noticing it, get into your doctor and they can start coaching you on some conservative therapies to try to keep it from getting worse.
I remember years ago doing a story when I was a reporter, television reporter, that there were some women that wouldn't go anywhere. They got to the point where they were so nervous about having an accident. That's sad. So
at least twice a week I'll have a patient come back from either surgery or some successful therapy, and not always in tears, but a lot of times they'll be in tears, and they'll literally say, "Thank you, you gave me my life back." Yeah, people don't think about it. There's a huge social aspect to it. So. We just have a couple minutes left, so I was wondering if you can just kind of quickly give the audience an idea of what is going to happen when you go to see a urogynecologist, because it's not something a lot of people go to, or a lot of women may go to, and it may be a little scary. So is there kind of a routine exam? Is it like a complete physical, or do you just focus in on whatever the issue is? Yeah, I think probably think of it as just like going to see your gynecologist and you're having a pelvic exam. It's really no different than that. In some ways, not even as bad. So that's the worst part of it. And so most women, for better or for worse, have gotten used to that by the time you see us. So nothing to be afraid of. We're not doing anything that's weird or painful. It's just kind of a good pelvic examination, normal pelvic examination. And then from there, even if you have to do urodynamics, it's just a very small catheter. It's not it doesn't require anesthesia or recovery. So most of the time, it's probably less of a nuisance than even just a routine annual exam.
All right. So sometimes, fear holds you back. So hopefully people will, if you're out there, maybe it's yourself or somebody you know or care about, share this information with them for sure.
Absolutely.
And the show is over, which is sad because it goes so quickly, and you have so much wonderful information to share. So again, Dr. Scott Boyd, really appreciate you coming on tonight. Thank you. And many thanks to all of you for watching tonight. Great questions. We have a wonderful audience. I certainly appreciate that. Have a good night, and we will be back here next week with Dr. Patricia Clark. She is a breast surgeon. She'll have a great amount of information to share with you as well. Take care. Have a good night. Bye-bye.
The preceding program on PBS Fort Wayne is made possible in part by
all the small things.